Good morning, everyone, and welcome to our first coffee and conversation for the 2025. We'll say summer because it's almost summer. We're very excited to welcome one of our faculty as our first speaker, although she is not in the US today. She's joining us from South Korea, so a bit of a time change, and so we appreciate her taking the time to be here. But we'll be hearing from Dr. HaEun Lee, and Dr. Lee's research focuses on improving health and health equity of low and middle income in low and middle income countries by empowering women as effectors of health for themselves, their families, and their communities. Her work encompasses better involving women's partners, families, community systems, and structures to promote women's health and gender equity. And she has more than 10 years of experience working in African countries, including Uganda, Zambia, Liberia, and Nigeria. Today, she's going to be telling us a little bit about her work related to couples in Uganda. I think we focused a lot on individual level interventions. And then at the Global Health Summer Institute, there was a lot of talk about kind of larger interventions, right, having to do with AI and technology. So we haven't focused much on kind of dyads like couples. So I'm excited to hear more about her work. And then just a couple notes, we are recording this, so I'll make this available on Canvas for students in HS 530 and 630 if you want to rewatch or if you miss any of it. And then we do have the captions available. So if you'd like to see captions, you can turn those on in any language that would be helpful to view those in. And I will turn it over to you, Dr. Lee.
Okay. Let me share my screen. Yeah, I'm currently in Korea and on my calendar, I'm still a little bit jet lagged. Korea's 13 hours ahead right now. So it's the evening, but not too bad. Um,
And we
can
will
everybody?
have time for questions at the end, but if you have something that's like pertinent to what Dr. Lee is talking about in the moment, feel free to use the chat or Q&A and we can interrupt and answer that as well.
Yeah, that'll be fantastic. Um, can everybody see my screen okay? Okay, perfect.
Looks good.
Um, yeah. Thanks everyone for having me. I'm really excited to give this talk and to meet a bunch of you guys, familiar and new faces. Um, I would like to share a little bit of my research related to postpartum family planning decision making for refugee couples in Uganda. I want to do a quick, oh, I'm trying to move. Okay, there we go. Quick acknowledgements for a lot of my colleagues and my partners in Uganda. I work very closely with faculty members at Bishop Stewart University, and we have some refugee research assistants that I've been working very closely with since 2023. And I would also like to acknowledge that this research has been approved by the Office of Prime Minister, as well as Bishop Stewart University and University of Michigan's IRB, and that I'm getting support from University of Michigan internal research funding to conduct part of this study, and that there's no additional conflict of interest to report. Since this is a little bit more of an informal talk, I thought it would be fun to include a little bit of my personal journey in global health. So I think I like to think that the global health, like the field, kind of chose me before I knew it, because a lot of my parents um, did similar work around the world. So I grew up in like seven different countries, and I was recently talking to my dad, and we moved more than 25 times before I turned 20. So that was fun trying to count all the numbers. So I'm originally from South Korea. This is when my younger brother was born. He is 2 years younger than me. And so we lived in South Korea until I was 4 years old. And then our family first moved to the UK for a brief amount of time. And then we went to Singapore. And then we went to Malaysia, where I went to boarding school as the youngest and the only Korean kid in the entire school. And then we went to move to Inner Mongolia of China, which we lived there for quite a few years until my dad was taking a sabbatical, and which we moved to Taiwan for a year, and then came back to Beijing, China, where I completed my high school degree in a local international school with a graduating class of 12 students. And then I came to the United States by myself. At the time, all of my family was still in China. I went to college in Grand Rapids, Michigan. I worked a year as a bedside nurse at a cardiac floor just to get some of my hands-on experience and to get a better understanding of the American healthcare system. And then I started my PhD in 2017 and completed in the thick of the pandemic in 2021, where all of my graduation was recorded over Zoom. And then during my PhD program, I worked with Dr. Jody Laurie, Michelle Monroe Kramer, Dr. Philip Valise, as well as Dr. Elisa Maffioli, to kind of look at maternity waiting homes and some of the barriers, especially the financial barriers in accessing these services amongst a couple, and how microfinance mechanisms can be helpful for couples to save and secure financial resources for them to access safe childbirth and etc. I did 2 years of my postdoctoral degree, also at the University of Michigan, but at the Center for Global Health Equity, where I got to collaborate with people from public health, medicine, anthropology, and so much more to work on some governance accountability projects, which I learned a lot, and started my assistant professorship here at School of Nursing in 2023. So I kind of think a lot about all the different type of implications of living in so many different countries and continuously traveling to multiple countries. And oftentimes I'm really confronted with a lot of the privileges that I have that's not earned. Um, and that so much of what I'm able to do is not because of who I am and the things that I've like studied or accomplished, but so much of it is also the people that I interact with and the systems and the structures that are around me. So naturally, a lot of my research focuses on how women's identities, abilities, and resources interact with our environment, social norm, and culture to impact our health. I work on a number of interventions to directly empower women with knowledge and resources, but also to improve the overall systems and the structure around women so that it's easier for them to navigate and it's working for them and not against them. So the project that I would like to share more in depth today is in Uganda, which is located in eastern part of Africa. Uganda is one of the largest refugee hosting country in Africa, with more than 1.62 million refugees residing, and most of them are from surrounding other African countries. And refugee women face significant barriers in accessing timely and effective maternal health services, such as poverty, loss of livelihood, different culture and languages that they have to adjust to, disruption of the regular healthcare services that they access, and severance from their existing social network. And while all of these factors influence their ability to access and utilize maternal health services, one of the critical factor is also the insufficient and ineffective male engagement. And African refugee men, just like many other men in Sub-Saharan Africa, play a pivotal role in making a lot of decisions related to household, but also like women's health, including, where they're going to access reproductive health services, family size, how many children they want and how much they want to space them out, and also providing that financial support to access these services. And there are a number of studies that show increased male engagement in maternal health is also associated with improved maternal and child health outcomes, just to list a few over here. And despite these benefits involving men, there is an overall lack of research on the role of men in maternal health interventions within conflict-afflicted settings. And so I primarily work in Nakivale Refugee Settlement, which borders Rwanda, Tanzania, and part of Congo. And it is the oldest refugee settlement in Africa. And it is the second most diverse, with more than 11 different nationalities represented, and is also the third largest in Uganda. Of the 11 different nationalities represented, predominantly is Congolese, Burundians, and Rwandese, which are the people that I work most closely with. And the birth rate of Isingiro district, which includes the Naki Valley refugee settlement, is 6.2 children per woman, which is significantly higher than the national average of 5.2 children per woman. And so I'll be sharing a little bit about some of the qualitative study that I did last summer. As I kind of briefly talked about, oh, in the beginning, it was more broad. I was trying to understand what are the general gaps in, male engagement in maternal health. But from that qualitative study, we further narrowed it down to postpartum family planning, and couples' relationship around that and communication skills. And I'll also share a little bit about what we will be doing this summer. I will be in Uganda 3 weeks from now for over a month with some students, and we'll be conducting some survey collection. We'll be adapting an intervention that we identified for the population through like a 4 day long workshop. And I kind of added a last piece of research trying to understand some of the recent changes in the settlement since January because so much of the global funding and everything has changed. So I thought it was really important to capture this piece because think it will have significant impact in our future research. And hopefully next summer, I'll be able to actually pilot test some of the intervention that we adapted. We are using the Adapt It framework to first assess the gaps in male engagement in maternal health, which we further narrowed it down to postpartum family planning. And we completed step 2 through 6, but through the adaptation workshop this summer, we are repeating step 3 to 6 one more time to further refine the manuals and the protocols. And hopefully next summer we'll be able to complete some of the trainings and testing amongst the refugee couples. So the previous qualitative study primarily focused on trying to understand the African refugees and key stakeholders' perceptions and priorities around men's engagement in maternal health. We conducted focus group discussions amongst refugee members, including both men and women. We conducted individual interviews with key stakeholders and using semi-structured interview guides and some demographic surveys, and collected it over in a span of 2 months last year and audio recorded, transcribed, analyzed, and now the paper is under review at a journal. And very briefly, at the individual interview, we collected data from healthcare providers, religious leaders, community leaders, and settlement commander. And on average, they worked in the settlement for over 10 years. Focus group discussions were conducted amongst the refugee men and women. And because we primarily targeted Congolese, Burundians, Rwandese, and Somalis, it was pretty evenly distributed. And on average, they lived in Naki Valley refugee settlement for over 12 years. And a quick side note is that refugee settlement is different than refugee camps. Camps are more temporary residential areas with the expectation that people are going to transition to somewhere else, whereas settlements are more permanent area for people to reside. And some of them actually have like Uganda's like citizenship, even though they are of refugee background. And Bishop Student University, which we are collaborating with, 1/3 of their student population are actually of refugee background, and they're located approximately an hour away from the settlement. So we used Lewis's interdependence model of communal coping and behavior change to guide some of the analysis. And according to this model, couples have predisposing factors that shape their transformation of motivation to address a number of health events as a joint concern rather than like an individual's health concern, which then further leads the couples to collaboratively approach and manage the specific health challenge that they're facing. And couples with effective communal coping involves partners understanding, discussing, and making decisions together to address the health issue, thereby fostering mutual support and promoting mutual health enhancing behaviors as well. And this model has been widely adapted in not only United States and high-income countries, but also a number of sub-Saharan African countries, looking at HIV counseling and testing, if anybody have a question, just jump in. I can't see everybody on the screen. And like diabetes, various cancers, and more. So this is the adapted model that we developed based on Lewis's model, based on some of the findings that we found. So at the predisposing factor, we further divided it into individual level and couple level. And at the individual level, we focused more on men's factors, which included financial status, because when we asked people what are the important roles that men play in maternal health, kind of ubiquitously, people were like, oh, men should be able to financially provide for the woman to access all of the services, was very important. A lot of people also discuss mental health because a lot of them suffer from PTSD, depression, anxiety, with everything that is going on, even though those are not the specific terminologies that they use. They also said that there was a significant gap between men and women when it comes down to maternal health knowledge, especially family planning, etc. And that a lot of the peer and community influence were a significant barrier for them to be more publicly and openly engaged in supporting their wives and being more engaged in maternal health. At couple level, we had perceived sense of like closeness, trust, and commitment, feeling like if they're able to have certain conversations openly, and both men and women feeling like they're able to negotiate, and people who didn't trust or didn't have had like low sense of commitment felt like one couple member didn't have that power to negotiate. And if one couple said, I didn't want to, have another child immediately, then sometimes the woman would worry that the husband will just have another child with a different woman, etc. They're also related to factors related to communication and joint household decision making. Couples that already had, a lot of conversations around various household topics and were making a lot of decisions together, were then also naturally a lot more likely to talk about maternal health issues and make those decisions together as well. Transformation of motivation were kind of captured based on how they talk about maternal health topics, whether they use language such as we, us, rather than like, oh, her pregnancy or her kid, and like my role versus her role, etc. And that's how we gauged how much, whether there is a sense of transformation of motivation or not. Communal coping, couples with effective communal coping were then having these discussions and decisions together related to a number of maternal health related topics. And consequently, it led to health enhancing behaviors, such as couples making decisions and behaviors together, such as saving for birth, attending antenatal care together, talking about postpartum family planning, sharing household chores while the woman is pregnant or taking care of kids, etc. So I won't go too much detail talking about the predisposing factors again, but there's an interesting quote from a Rwandese men talking about that transformation of motivation. He said, as a husband, you have to do everything, taking care of the kids, cooking, and ensuring your wife has nutritious food to stay healthy for childbirth. You must save money to provide for her needs and prevent her from carrying heavy things. Um, we found that pregnancy, when the woman is pregnant, is actually an optimal time for couples to exhibit that and go through this transformation of motivation. A lot of the people had very clear and strict gender roles around what men do in the household and what women do in the household. But when the wife is pregnant, the husbands were a lot willing to take care of kids and cook and do all these things that are traditionally a woman's role. So we thought that was really interesting. These are a couple quotes that kind of show some of the effective and ineffective communal coping. And I'll give everybody a few seconds to read them. And the main difference here is that effective communal coping happens when they're able to have these conversations as like equals and have that conversation in an ongoing matter, negotiating and making decisions together. Here they're talking about family planning and what happens if, plan A doesn't work, what they're willing to do, etc. Whereas ineffective communal coping is one person not feeling like they have that negotiating power and not able to have that discussions in an equitable manner with the other partner. These are some of the most commonly brought up health enhancing behaviors. This includes using family resources for maternal health services, attending antenatal care and various checkups during pregnancy together, using and talking about contraceptive methods and making that decision together, and sharing household chores. I'll give everybody a few more seconds to read through these. So yeah, knowledge and information gap were identified as a significant barrier to male involvement. A lot of them said that there's a lot of interventions at the refugee settlement that targets women and children, but there really isn't anything for men, especially related to family planning. And so then there was a significant gap between what men know and what women know. And so when they are trying to have these conversations, it's just really not productive. They also talked a lot about peer influence playing a substantial role, and that men, more so than women, are more likely to be influenced by what other people think and what other men and like community leaders tell them. And so they said whatever intervention that we develop needs to be more men focused and it needs to be in a group setting so that this type of peer pressure turns into a positive peer pressure. Again, couples who already engage in open communications and make decisions together were more likely to also talk about various maternal health topics together. And that pregnancy was identified as a prime time for both men and women to have high transformation of motivation to then also exhibit effective communal coping and behave toward positive health enhancing behaviors. And a lot of participants, both men and women, said that at the end of the day, men are head of households and they have the final say in, family size and how many, kids and, what type of contraceptive method that the woman should or the couple together should or should not use. But there really is not a lot of intervention that effectively engage refugee men and tell them about the various side effects that they might experience together as a couple and how to address them. And that this type of conversation should happen in an ongoing way. Of the broad maternal health topic, we found that family planning was really not discussed between couples, and there were a lot of tension between couple members when they're trying to discuss this, or sometimes women want to space it out, so they will just go and get an implant or a shot, and the husband later finds out because she is going through various side effects and causing a lot of tension and sometimes even some violence. And so that we identified that family planning is very important and it needs to be specifically tailored for men. And then to engage couples together, have this conversation, negotiation, and decision together. And to also focus on couples' relationship and communication skills to not also only improve postpartum family planning discussions, but that the implication of this is beyond that. So based on all of this, we kind of identified an intervention that we wanted to adapt. It was originally developed by Dr. Lene Darbs, who is also at the School of Nursing. Her intervention, which is called Uthandu Luethu, which is a couples counseling, individual couples counseling program that we are adapting into a group couples counseling program. And she originally used this intervention to improve couples' communication strategy, communication skills, talking about very like difficult topics, and improving the overall relationship qualities to ultimately improve couples' HIV testing and counseling. But we are using that for postpartum family planning. So there are three research activities that we are trying to complete over the next 2 months. First, we are conducting a cross-sectional survey amongst 210 refugee couples. We are recruiting 70 couples per nationality to kind of test the independent and dependent variables that we identified in the conceptual model. We will also be conducting a 4-day workshop with the key stakeholders, including healthcare providers, religious leaders, community leaders, etc., and also recruit some of the refugee couples from the various nationalities to help us further refine the manual that we kind of drafted up based on the original intervention and based on our qualitative study findings. And the healthcare provider interviews will try to assess some of the recent changes in resources, etc., and its impact on patient care and maternal health, as well as postpartum family planning. So we developed a pretty comprehensive survey that kind of consists more than 200 questions, but we pretty much pulled up various tools that have been validated and tested in sub-Saharan Africa. Some of them have been tested on refugee populations, some not. But we tried our best to kind of pull various tools to map out specific individual and couple level factors, as well as the outcome that we are interested in, which includes communal coping for family planning, male engagement in maternal health, individual family planning desires, intentions, and contraceptive preferences. So then we can match the men and the woman's answers to see how far off they are, or surprisingly, they might actually, be the same. We don't know, but that's what we're trying to look over the summer. These are some of the inclusion and exclusion criteria that we have. We are recruiting women that are 15 to 45 years old, and for the men, as long as they're older than 15 years old, it's okay. And we originally had it at 18 years old, but a lot of the participants were like, teenage pregnancy is actually a really big problem within the refugee settlement. So then we further lowered it to 15. They have to be married or be in a committed relationship for 1 year or longer. They have to be currently pregnant within the 20 weeks or less. And they have to be, been living in Naki Valley refugee settlement for 1 year or longer. They have to be fluent in Kiswahili or Kinyarwanda, which are the two dominant languages that Congolese, Rwandese, and Burundians speak. And we're using a WHO IPV guide to screen out any couples that have experienced any moderate or severe physical or sexual violence in the past 6 months. And both partner members have to agree to participate at the original recruitment stage. And this is a broadly anticipated, intervention that we have planned out, and we have specific questions that we're going to ask during the workshop. But the original Uthendu Luethu intervention is all individual couple session, which was found to be effective, but it was also very resource intensive and time consuming. And given that a lot of men wanted a group intervention, that they're able to have this type of conversation just along with men. We have certain sessions that are just for men and certain sessions that where we have both couples participate. Some of them are separated out by gender, some of them are together. And these are the various topics that each session will cover. We're kind of starting out from broader, more generalized and not very sensitive topics to then like kind of going down into more challenging topics such as, postpartum family planning, gender dynamics, etc. And we also have a lot of time built in for individual couples to learn the skills and then like go and practice and have certain conversations and then come back and we sometimes like share some of the thoughts, etc. For the adaptation workshop, we are recruiting 10 to 12 key stakeholders, 6 refugee couples, and we'll be conducting focus group discussions that sometimes everybody will be participating. Sometimes we'll be separating out the key stakeholders and the refugee couples. Sometimes we'll further separate them out based on gender, and we'll be asking, how do we time each of these sessions? How long should we give between each session. And we found out this is actually a pretty important topic because a lot of the refugee men travel outside of the settlement to earn money, and sometimes they're gone, half of the week. And so we really need to pick a time where couples can come together. Um, to not only participate in the survey, but to get a general sense of the interventions and how we can make it best work for them. And we also found that depending on the nationality, they have different type of myths around contraceptive methods and some of the traditional methods that they might use within their own culture. And we really want to try to understand what those might be, because they might vary quite a bit depending on nationality and culture, etc. And we are still not 100% sure what are some of the contents that needs to be delivered together when the couples are together, versus some of them that needs to be separated out to really enhance some of the discussion that they might be having, and that it might be really a little bit awkward when they're together, and trying to understand some of that based from the workshop. And a lot of people also talked about financial literacy and income generating activities that they can do to make more money. But we are also trying to further understand what part of financial literacy that they're trying to understand, and how do we teach this content for couples together to have also these conversations around money in a productive sense. For healthcare providers, we are recruiting up to 25 healthcare providers and from different types of healthcare providers. And we'll be recruiting across all 7 different facilities in the 3 different zones of refugee settlement. And we'll be recruiting via flyers, public announcements, and word of mouth. We already have a few healthcare providers that we've been working very closely with. So we'll probably tap into that connection. And we'll be asking, whether they have noticed any changes in the settlement or the healthcare environment. If yes, how are these changes affecting the care that they're providing? Anything that are specific to maternal health and family planning? Because previously, when we had these conversation informally with the healthcare providers last year, they were pretty well stocked with all the different type of modern contraceptive methods. So they actually didn't experience frequent stock outs. And and so we didn't really think that this would be a very big concern. But with everything going on, this actually might be a factor that changes our research finding. And we will also be asking them what are some of the foreseeable, new additional changes that they see, and what they might need in the future to provide quality care, in consideration of everything that is happening. Some of the expected outcomes through the survey, we are hoping to understand some of the associations and the strength of the associations between independent and dependent variables that we identified in the conceptual model. It'll be a really good practice for us to test for the feasibility of recruiting couples together and testing out surveys that will also be used for pilot intervention. The workshop will provide additional insights for us to polish the intervention protocols and the manuals and set up for the pilot intervention next year. And for the healthcare provider interview, we are trying to understand, as much as we can, and regarding some of the recent and future changes that might be impacting the healthcare resources in the Nakivale refugee settlement. Hopefully next year we'll be able to do a pilot intervention amongst 45 couples. We are thinking 15 nationalities, 15 couples per nationality, and they'll be all participating across all the 6 sessions. And we'll be collecting the survey at pre-intervention, post-intervention, and 3-month postpartum. And the versions for the outcome variables vary a little bit. And ultimately, we are hoping to see that refugee couples' equitable and concordant discussion, decision-making, and behavior toward postpartum family planning. And we are not necessarily telling them that modern contraceptive methods are better than, doing, counting your fertility cycles, and some of the more non-medical, non-hormonal methods. But the outcome that we want to see is that couple members coming to an agreement and having the same answers when they think about family size and how much they want to space and what are the different type of contraceptive methods that they want to use, etc. And we hope that this intervention will improve couples' relationship and communication skills to equitably discuss, negotiate, and decide on various household related decisions that are beyond postpartum family planning, and that yeah, these topics shouldn't be just targeting men or just targeting women, but really bring both men and women together and address them as a team and address them as a unit to promote healthy family and healthy community amongst refugee population. That's kind of all I have for today. I'm really excited to have more conversations with all of you and get some questions. I see that there are some of them, so thank you.
Thank you so much, Han. All right. Well, we have not a giant group, so please feel free to use chat, but you can also unmute or raise your hand if you have questions, and we can just have a conversation about this as well. But I really appreciated learning a little bit more about your work, and we have a couple of students that are actually envisioning a DNP project with Ruth Zelinsky
Okay.
using cycle beads, and
Oh
so.
yeah.
I'm not sure if they're in a space to ask questions, but while they're thinking about that, because I think there's Renee. Renee, do you have any questions? I know you're at work, so if you're able to talk, we can give you the option now.
Oh, I actually think I have a lot, and I would actually maybe like to get in contact with her afterwards because I think they're very similar. And I even think there could be an extenuation of my project with some of the things she's doing for maybe Heather. So if I could maybe get her contact information afterwards, there could be a much bigger conversation I'd like to have than occupy
Of
every.
course. I will just put my email in here and feel free to email me. And
Perfect.
I did work with Ruth on some of her healthy men and healthy
Yeah.
family intervention back up in what's that settlement called? Why am I Ajumani
Yep.
refugee settlement? Yep.
Yep. Where I'll be
Yeah,
going.
and I'm actually pulling some of the content from that as well, a little bit, but
Well,
yeah.
and mine is my project is mostly going to be working with the women, but I like the
Okay.
inclusion of the men because it is you have to get both of them working together for any of this to be successful, right? So
Exactly. Yeah.
obviously my project is going to be focusing more with teaching the women, but maybe the extenuation would be that some way we work in with the men in the future or something. So I would like to talk to you further. I will contact you. Thank you. It was a great
Yeah.
presentation, very exciting.
Uh-huh. Amazing. Yeah.
Yeah, Han. So they're looking at doing cycle beads. Actually, Renee is proposing couple beads, which is a
Okay.
combination of tracking your cycle plus the ovulation, the Billings method.
Okay. Oh,
Um,
wow.
but it's the DNP projects are relatively short, and so I don't know
Okay.
that there would be the opportunity to engage, couples or partners at this time. But Heather is a year behind Renee and is interested in continuing the project potentially.
Yeah.
So there might be some really great things for Heather to think about. What would the next step if they piloted the cycle beads and it worked well in this population? Would it be getting engagement potentially from male partners or other stakeholders in the community?
And I think that's like amazing because I would like to learn a little bit more about the beads because I know like Ruth had that and like with Jody, they worked on a few things together. And I really want to also focus on them to how to use those methods effectively because they could be really effective. But we are very heavily focused on like modern contraceptive methods and the side effects really are not great. And I know the importance of, planning for spacing out birth and limiting birth and all that, but the existing family method, modern contraceptive methods all suck too. So I would like love to like learn more and also incorporate some of them into like our training manual as well.
Yeah, and Ruth had it was interesting because it's, not only about kind of health and improving maternal and neonatal outcomes, obviously with pregnancy spacing and some sort of management of or some fertility planning, but Ruth was also very interested in the beads because she thought they could potentially be made in
As an
Uganda
income
as
generating
well. Like
activity.
it's some so going back to like the Global Health Summer Institute
Ah,
and this idea of innovation, she had reached out to the business school, like could there actually be some sort of business where these beads,
huh.
right? So either necklaces or bracelets or some sort of like
Huh.
beaded device is created in-house, right? And then it becomes really
Yeah.
sustainable because you're not dependent on getting modern
Us. Yeah.
contraceptives into the settlements or whatever might be necessary for family
Yeah.
planning as
I need
well.
to reach out to Ruth and talk a little bit more about all of this too. Yeah.
Yeah. So I Heather, do you have a question? Go ahead.
Oh, I was just going to chime in off of that. I'm super excited about what you're talking about because I agree with what everybody said. Renee is going in to kind of start, and we're going to see like what comes from that. But given the research you found, it does really spark my interest in, potentially training the couples because that involvement in, these populations and these cultures is so important, like your research has shown. And so that makes me really excited because we've been kind of trying to think through like what is the continuation of the project, and obviously, sorry, my son's coughing. What is the continuation of the project? And obviously, it's a little premature because she hasn't gone and done anything, but it's super exciting to utilize your research and maybe extend this. So I'll be excited to talk to you as well. You'll probably be hearing from me in
Yeah.
the
Amazing.
conversations too.
Yeah. I love it. Uh-huh.
Any other questions for Dr. Lee? I have a question I could kick off with. So a few of our students here, so Renee, Sandra, and Jimmy are just getting started with their projects. And one of the things you mentioned early on, some of your results from the qualitative work were the different stakeholders that you connected with, right, and interviewed. And so there were religious leaders, community leaders. I don't know if you specifically said elders in that list. But I'm wondering kind of how you identified which stakeholders were important to talk to. And even if your interview guide or the questions or the goals of those interviews were a little bit different as well.
Yeah. So I think this is why it's really important for everybody that does global health work, especially who's based on the north side of the globe, is really to have like really good collaborators. Because I've been working with Bishop Steel University for like 5+ years now, and they are a much smaller university, but they are very conveniently located, like very closely to the refugee settlement. And their chancellor, as well as the rest of the school, is very have done a lot of different type of projects within the refugee settlement. So they had a pretty vast network. And the fact that I came being associated with them were already a huge like that people were a lot more open and willing to meet with me and have this conversation. And so it wasn't anything that I did to be like, oh, I need to talk to these people. But a lot of the people telling me like, oh, if you want to engage men, if you want to engage women, you can talk to the husbands and they will have this conversation. But if you want to engage men, you need to talk to the community leaders, but because they are the ones that are being respected and how important religion is amongst these population. And so we kind of like reached into multiple different like denominations within that large branch of Christianity. And it also did help that the chancellor of Bishop Stewart University is a bishop, so he actually has a lot of power and a lot of network. So he had a lot of extensive connection and was very supportive of this project that further connected me too. So I kind of like really benefited from everything that was already going on there. And originally I wasn't even interested in like refugee stuff, but every time I go visit Uganda, my collaborators from BSU, I'm like, you need to do something with, refugee people, refugee population, because they really have a lot of need and we are working with them. You have to come with us. So then I like made a little segue and everything kind of like happened from there. So really trying to like listen to my collaborators and the things that I've identified and really tapping into the connections that they had and the advice that they gave me that I need to talk to the religious leaders from like a number of denominations and the community leaders that are, in charge of these like specific zones, healthcare providers, talking to the office of the prime minister and the settlement commander that oversees all the research projects. Yeah, it was very like interesting to get like permission even from the office of prime minister. You need a hard copy letter to enter the settlement. So all of that was very much like I kind of lucked out. I always feel like I like get to do the fun part where I like talk to people and like do presentations and like do research, but they really do a lot of the hard work on the ground.
Thank you. I think that's a good reminder for those of you starting projects to just think really broadly about the stakeholders and connecting with some of the stakeholders, even if it's not through formal interviews, is really important and helpful, and something you could even start remotely, potentially, right, to get a little more information related to your project. There's actually a question in the Q&A from Ibrahim, who is joining us from Ghana, and they ask, would if you'd mind extending these findings to Ghana and what this could potentially mean in Ghana.
Oh, that's a great question, but I haven't really worked in Ghana specifically, like north part of Africa, like Nigeria, Ghana. I feel like people sometimes think that they're very similar, but I also think they're quite different. But I think overall, it's not just Sub-Saharan Africa, it's not just LMIC, but I really do think, the past like few decades really has been about like empowering women, um, and men really felt like they were not being actively engaged in these conversation, whereas yeah, but we really are not like you don't take power from men and then give it to women. Like we are all mutually trying to grow and like what's good for the woman is good for men and what's good for men is also good for women and that we are all like a team, like unit as a couple, as a family. We are all supposed to be supportive and like kind of grow and together. But I really do think men has been excluded in a lot of these conversations and men know that. Like whether it's, income generating teaching like women how to make money. Like even the microfinance interventions that I worked in as a PhD student and up until now, it's primarily targeting women. And they have good reasons for that because, when women gain a lot of money, like more percentage of the money go to the children's education, nutrition, etc. versus sometimes men might use it in like gambling and like alcohol and etc. And there might be good reasons why these interventions have traditionally been targeting women, but really, if you really want to collectively make this a sustainable change, you really need to address both men and women together. So I really do think it's like a global thing that we need to bring both men and women together. I feel like up even in the United States, we see a lot of tension around strong independent women and then, men feeling like they're being threatened and there's all these conversations ongoing. Um, and it does take more time and it is more, energy resource consuming, but I think if you really want sustainable change and really help both people understand that, you know, what's good for women is also good for men. And it's not like we're not pitting anybody against each other and that it's for everybody's good. Um, so I think that might be also generalizable to not only Ghana, but a lot of other contexts as well.
Yeah, and I think there's other factors there too, right? Like religion, certain areas in
Yeah.
Ghana, there might be differences in really thinking about how to incorporate partners and families
Mhm.
even in
Yeah.
some of the decision making, depending
Yeah.
on culture and religion within a country as well.
Mhm. Yeah. And when I like talk to men, they are overall very interested and they do want to learn more, but they feel uncomfortable, going to group antenatal care when there's like 20 other women and you're like one of three men and to get the education. And so there's, I feel like a lot of barriers and it's not really tailored for men. So a lot of our intervention when we deliver it, it's like, oh, what does it mean to be a good husband, a good father, and a good man? And that like, why is spacing out birth good for you? You're able to like, you just said that you feel really strongly pressured to financially provide for your family and it lifts that up if you're able to space that out a little bit. And like having to pick which kid goes to school and etc. You don't have to pick that if you have like three instead of five kids that are like spaced a little bit out. So we try to like incorporate some of those messages to tailor to men a little bit more and then bring couples together to have this conversation.
Yeah, and to link it back to the Summer Institute, I'm not sure if everybody was able to attend the session where Mustafa Nassim talked about his project in Pakistan, but it was basically men could dial in and get more information about pregnancy. And there it really was a knowledge gap. So I'm imagining that that comes up in your work as well, huh? And just like not understanding different contraceptive methods or even kind of fertility. Like, I know in the US we continue to have pretty bad sexual health education.
Uh-huh.
That can happen around the world. And so, I mean, I think some of it is just education and safe spaces to ask those
Mhm.
questions or have those conversations as well.
Yeah. Because I think a lot of the education, especially related to contraceptive method, people don't talk about the side effects as much. And so people don't know what's serious and what isn't. And so like if the woman is like spotting, like it like she might like not, be, not able to have any more kids and people get scared. And a lot of the, women also experience like vaginal dryness, which impacts their sex life. And then they don't talk about this as a potential side effect and how to like deal with it. So then like yeah, from like men's perspective, it also is yeah, very challenging for them to like wrap their mind around if they don't fully understand what the benefits are. So, yeah.
Great. Other questions at all?
Hi.
Hi, oh, go ahead.
Hello.
Okay, from me or Dr. Lee. Okay, I would like to share about specific in the cancer. It's not the maternity, but I would like to share from my experience. It's like
Mhm,
when we study about the family dynamic for the
mhm,
couple. Yes, because for my PhD, 10 years ago, I study about men caregiver, take
okay,
care of patients living with cervical cancer in Thailand. Lots
okay.
of many issues surrounding from the men because they're suffering from the
Mhm.
cancer. I know, but from the interview, have you planned to interview with men and women at a couple, or just only a man in your project? Sorry,
Mhm.
I walk. I'm not clear some point. Sorry about that. I would like to
Yeah,
know.
no, it's all good.
Yes. Okay.
Yeah. So a lot of the design component, we include both men and women, like the original qualitative study and the adaptation workshop, we are all including both men and women to hear their insights. But we found that a lot of the maternal health topic,
Mm-hmm.
whether it's contraceptive methods like pregnancy and childbirth, there are a
Uh-huh.
number of educational opportunities for women to access these information and knowledge, but there isn't
Uh-huh.
any for men to comfortably go and ask these questions. So then
Mm.
the actual intervention itself, we have like one session that where all the couples that we recruited are coming together and we are setting ground rules and like helping them understand what we're going to do. But then we
Mm-hmm.
have two sessions that are more specifically for men to talk
Mm.
about, family planning from their perspective, mental health from their perspective, like
Mm.
stress, um, the burden of being a, head of household, the burden of, being a husband and all that type of
Mm-hmm.
stuff. And
Yes,
trying
yes,
to build that community amongst
yes,
men and
yes.
then bring in their wives to be
Mm-hmm.
like, yeah, like what are some of the communication strategies that we can use to learn from
Mm-hmm.
each other, how to have like negotiations properly. We have like, like different listener and like speaker technique using I
Mm-hmm.
language versus you language, and we have all these activities built around that so that
Ah,
they're
it's
able
very
to
nice.
yeah, have this conversation in a productive manner. And then later we are like, oh, now, practice the skill talking about family planning, practice the
Mm.
skill talking about, sense of commitment and trust that
Mm.
perceive within your relationship and all that
Yes,
type of stuff.
yes. Can I share a little bit about the nature of masculinity role in my country? It's like
Yes, of
the back.
course.
Yes, the background in Thailand is sometimes when the men present among the a big group. They didn't
Hmm.
say anything about
Oh,
sufferings or anything,
mm,
but when we separate men to interview, lots of things that coming out. It's like a factor that affect about their perspectives, about their daily life. For example,
mm,
in Thailand, it's an extended family. It's
huh,
sometimes couple living among the big family, and sometimes it have a social expectations that impact to the men role. For example, men need to go to it's like to make a money outside the house, and
mm,
for the handle between a struggle between the role of the caring of the woman and
yeah,
making the money, and
uh-huh,
sometimes they feel guilt. It's like they not have time to take care of
mhm,
the woman or something like that. It's very
yeah.
very very good project. It's very interesting, Dr. Lee.
Thank you.
Okay.
Yeah, thank you for sharing what
Yes.
you are experiencing in Thailand as well. Yeah.
Yeah, yeah. Okay, thank
Uh-huh.
you.
Yeah. Thank you.
Thank you, oh. Any other questions? And this could be about, Dr. Lee's project, or even I appreciated the baby pictures, but even kind of the pathway to global work as well.
Shy group.
Yeah. The other thing
Random comment.
go ahead, Jimmy. Yeah.
Yeah, sure.
Dr. Lee, did you work on 7 Heart or 6 South at
Oh, I
Butterworth?
worked at Six Heart. Yeah.
6 Heart? Okay. I
Uh-huh.
worked on
Yeah.
5 Heart, so
Okay,
sorry for
nice.
showing. Oh my gosh.
Yeah. Oh my gosh. Yeah. That was something.
Good
I
times.
admire
Throwback.
everybody that's at the bedside. I still teach some clinicals with sophomore students, and there are days that I'm like, oh, I think I miss bedside. And then I go there, I'm like, I don't miss it that much.
It has its
So
ebbs and flows, doesn't it?
yeah, I applaud
Yeah.
everybody.
The one
Miss
other
you,
thing
Renee.
I wanted to point out for our DNP students, so in one of her slides, Dr. Lee showed the Lewis model and kind of the application to the results. But for your DNP projects or really any project, right? Like we're asking you to think about frameworks and models. And for the DNP projects, it's specifically the implementation framework or model. And so think about using the application of it, right? So like what variables might you measure or what outcomes might you expect from the model that you're using? You're likely not going to be able to assess a full framework or model in a 9-month time period, but you can kind of emphasize like this is the piece I'm working on. And like for you, Renee, maybe this is the piece that you're working on, and this is the piece that Heather or another student could continue on. But when I think you're learning about those models in your course with Dr. Maslowski, really think about the application because a model is really just a framework or a way to think about how concepts or different items relate. And so how does that specifically apply to your projects? I really appreciated seeing that model and framework filled in with your results, and exactly how it applied in your project.
Thank you. Yeah, I need like the visual practicality of it because
Yeah.
I don't like conceptual and theoretical models that much. I'm like, tell me how to use it.
All
Uh,
right. Well, we are about at time. I'm not seeing any other questions. So I just want to remind everybody that we will have the Coffee and Conversation series at 8 a.m. For the next 3 weeks.